Hello, sir. I'll be hosting your session today, sir. Are you ready? Okay, sir. Just log in, sir. I've already logged in. Okay, sir. Hi. Hello, yes, sir. Yes. Make it the post, sir. Yes, sir. Yes, sir. Yes, sir. Yes, yes. Sir. I'll give you the info and then you can join in, sir. I'll make you the co-host for me. Yes, sir. Okay, sir. Good evening, everybody, and welcome to today's session. Today we have with us Dr. Dipu from the Infectious Department. Hello, sir. and he will be talking on the practice pearls for antibiotic prescriptions. Can we begin, sir? Over to you, sir.
Yeah. Shall we start?
Yeah, sure, sir. Over to you.
Am I audible?
Yes, sir, you are.
Okay. I think Sabha, you have to start using two instruments, two phones. It is sound is getting activated.
I didn't get you, sir.
I think you are going from two mobiles.
No,
Have you?
I am just connecting with this hotspot.
Oh, because my sound is echoing, so I'm wondering whether it is some kind of.
I'm not very sure, sir. Akash, close the door, no? Is it better now, sir?
I think it's better. Yeah. Now it's okay.
Better now? Can you hear me?
Shall I start?
Yeah, sure, sir. Please do.
Am I audible?
Yes, sir, you're audible.
Issue.
No, sir, you're audible.
Okay. Then let's start. Good evening, friends. So I am Dr. Dipu. I think most of you would know me. I'm associate professor in the Department of Medicine and leading the infectious disease division of Amrita Hospitals. So today we will see a few practical pearls regarding the antibiotic prescriptions, because this is something which we do daily in our clinical practice, and there are a lot of intricacies. It's very difficult to cover all the scenario, and that is not the aim also. Aim is to just sensitize all of you regarding the good prescription practices and the intricacies which is involved in prescription practices, so that you will be aware when you come across such situations, or if you are in doubt, you will be able to get the appropriate consultation to ensure that you are doing the right thing. So let's discuss few scenario. The first scenario is, most of you would have encountered, at least in your UG days, the scenario. That is a 52-year-old male patient admitted with alcohol withdrawal syndrome, and he was in the wards. But later, because he is in alcohol withdrawal, his consciousness level would get fluctuated, and 4 days later he developed high-grade fever with crackles on the lower zone of the chest, along with elevated counts. So we definitely did a chest X-ray which showed aspiration in the dependent portion. So the diagnosis is pretty straightforward. It is aspiration pneumonia. So as clinicians, we generally do a good job in diagnosing the syndromes, but then diagnosing so that we can make an optimum management and help cure the patient. So the impression was aspiration pneumonia, and the treatment given was piperacillin tazobactam with clindamycin. When we started the antibiotic stewardship program of Amrita Hospital, we used to see a lot these kind of combinations, piperacillin tazobactam with clindamycin. Why clindamycin? Because we all know that oral secretions would have been aspirated, and the oral secretions contain the anaerobic flora. So that is the logic behind giving clindamycin to cover the anaerobic. As we know, metrogyl will cover the anaerobic, clindamycin will cover the anaerobic. But what is the obvious problem over here? If anyone want to shout out, that's fine. Otherwise, I will just continue. So the obvious problem is piperacillin tazobactam also has good anaerobic coverage. So in presence of piperacillin tazobactam, there is definitely no need to add another antibiotic which has anaerobic coverage. So piperacillin tazobactam alone is enough in the above scenario. What about ceftriaxone alone or something like a respiratory quinolone like levofloxacin in a patient whom we are suspecting aspiration pneumonia. So the guideline says that even though if there is a odontogenic infection, is for example a patient has gum infection or odontogenic infection, then the aspiration will contain a lot of anaerobes, and in such situation we will have to definitely give something like piperacillin tazobactam, or we'll have to add something like clindamycin to cover the anaerobes. But in majority of the scenario where the aspiration is mainly the gastric content that is causing the aspiration pneumonitis, the acid content of the gastric acid will cause something called aspiration pneumonitis rather than a true aspiration pneumonia, in which scenario ceftriaxone or a respiratory quinolone like levofloxacin is more than enough. But whereas if there is a dental infection or if there is a gum infection, peri gum infection, then definitely we need to give piperacillin tazobactam. But at any scenario, there is no need to give two anaerobic coverage. So piperacillin tazobactam with clindamycin or piperacillin tazobactam with ventrotide, those kind of combinations we can definitely avoid. So this practical pearl we can use in other scenarios as well. If we remember that dual anaerobic coverage is not required, that will cause more harm than good. For example, if you are giving piperacillin tazobactam with clindamycin, that patient has a higher chance of developing antibiotic associated diarrhea and even Clostridium difficile infections. So this is something which we can make use of in our daily practice. So coming to the scenario 2, that is duplicate therapy. Let us discuss the scenario. 50-year-old male presented to the hospital with fever, warmth, and pain of the right lower limb. So from the history we can know that it looks like a cellulitis case following an injury to the lower limb, diagnosed as cellulitis and started on piptas and clinda. Okay, so again piptas and clinda, but here the scenario is kind of different. Here the patient has a cellulitis. So cellulitis means there is an infection of the soft tissue. The folliculitis means infection of the hair follicle, and it is mainly confined to the epidermis. But once it is involving the soft tissue, then we will call it as cellulitis. And whenever there is a cellulitis, there is always this predisposition of the infection to go little down and to involve the fascia. And once it involved fascia, then it will become a fasciitis, and there could be necrosis of the fascia when it will become necrotizing fasciitis. So depending upon the depth, the infection will go on and on. Below the fascia there is muscle, and then it could be necrotizing fasciitis with myositis. If it involves the bone, it will become osteomyelitis. So just to get you an understanding regarding how with the depth the scenarios will differ. So why I wanted to explain it a bit is that whenever we are dealing with the cellulitis, there is a possibility of fasciitis or necrotizing fasciitis. And necrotizing fasciitis, most of the time, there will be a streptococcal or staphylococcal infection, which can produce toxins. So this is an exception to the general rule where we need not give piptas and clindamycin. Actually, in this scenario, we can give piptas and clindamycin, not because of the anaerobe, but clindamycin has anti-toxin activity. So for the anti-toxin activity, we can actually give piptas and clindamycin in this scenario. But the story is not ending here. There was a pus point from which our surgery team has sent cultures, and the organism turned out to be MSSA. So now what will you do? So whenever you get an MSSA, here piptas and clindamycin. So now we know the organism. It is a methicillin sensitive Staph aureus. So it is a sensitive Staph aureus. So definitely we need not give higher antibiotic like piptas and clindamycin. You can de-escalate to something like flucloxacillin or cefazolin. But in case if you want to ensure a broad spectrum antibiotic, and if you are suspecting that there could be a polymicrobial infection and you don't want to de-escalate just to cover the Staph aureus, then you can just keep the piptas and you can avoid the clinda, because now we know that it is an MSSA. Or if you want to just give the clinda, that is also fine. You can just give the clinda and can avoid the piptas. So because both piptas as well as clindamycin will cover the MSSA independently and individually. So there is no need to give antibiotic with same spectrum of activity again and again. So that is the concept regarding the duplicate therapy. So this is something which we need to remember. Once we have the organism, then we need to hit the organism only with one antibiotic, but which is, and just ensure that the antibiotic which we are giving is actually sensitive to that bug. So let's discuss the scenario 3, that is syndromic diagnosis and its pros and cons. So in medical practice, most of the time, as we already discussed, we will diagnose the syndrome as aspiration pneumonia or skin and soft tissue infection like cellulitis. So why we want to have a syndromic approach? What are we trying to achieve by having a syndromic approach? So whenever we say that a patient has an aspiration pneumonia, then we know that we have to consider anaerobic organisms, and we have to consider mainly the respiratory and oral flora. So that is the respiratory and oral flora, GNB in the respiratory and oral flora, as well as the anaerobic organisms are the one which is going to cause infection. And when we are dealing with a skin and soft tissue infection, more often we are going to have a gram-positive organism than a gram-negative organism. So once we have a syndromic diagnosis, then we can make an intelligent guess regarding the etiological agent which is responsible for that particular syndrome. So that is why we are trying to always achieve a syndromic diagnosis so that we can tailor the antibiotics accordingly. Okay, so this is the scenario. 42-year-old male presented to OPD. This is our daily day-to-day scenario. Any MBBS doctor who is practicing in the periphery or who is sitting in our general OPD, at least one patient will come to you with fever, sore throat, and cough of short duration. And most of the time, if it is a fever, sore throat, and cough, we know that most of the time it will be a viral syndrome. But sometimes on examination, if you are seeing these kind of patches in the tonsil and the posterior pharynx, then we tend to think more in terms of a streptococcal pharyngitis. So streptococcal pharyngitis, we tend to treat with our classical augmentin or even simple amoxicillin. That is okay. So that is the pros of having a syndromic diagnosis. We know that there will not be an E. coli pharyngitis. There cannot be a gram-negative pharyngitis. So pharyngitis means it has to be a streptococcal pharyngitis. So then we need not give any other high-end antibiotic. We can give just amoxicillin, or if we are suspecting some kind of resistance, even augmentin we can give. Now, but being in Amrita, if you want to clinch the diagnosis, or sometimes the patient might tell, okay, I would like to know whether it is really streptococcus or not. Then here we have the option of doing gram stain, culture, rapid antigen card test to know if it is a streptococcus or not. Do we routinely do this? Because of the cost constraint and the time involved, most of the time we tend not to do, but still there are exceptions, and sometimes if the patients would like to get the diagnosis, we will definitely do it. We have the expertise over here. Many healthcare facilities in the developing countries lack the equipment and training personnel required for etiological diagnosis of infection. So this syndromic diagnosis will help to administer the appropriate therapy in majority of the cases. But this particular patient, after starting amoxicillin, 2 to 4 days later, his symptoms worsened and he developed this rash. So once you administering an antibiotic based on a syndromic diagnosis, then if you need to follow up on the patient, and if you are seeing some atypical manifestation, you should be able to investigate further and think that it is not really fitting into a classical syndromic diagnosis. There are something atypical which is happening, which we need to be aware of. So in this particular patient, after a penicillin, there is a rash. So we have to rethink. Amoxicillin induced a drug rash in a suspected case of streptococcal pharyngitis. So what is it? So we can do a simple peripheral smear, and there were atypical lymphocytes. So diagnosis was Epstein-Barr virus infection. Anyway, so the basic blood works also was suggestive of a viral syndrome rather than a bacterial syndrome. So this is some though there are a lot of pros which we already discussed about the syndromic diagnosis, one cons is that unless we are careful, the typical manifestations or the rare presentations of these viral syndromes we will miss. So we need to have that when we manage a patient with a syndromic diagnosis, the within the gamut, not everything might fit within the gamut, and those things we need to be aware of, so that we will not miss the diagnosis completely. So take-home messages in syndromic diagnosis, though the approach is to cover the most likely etiologies, if the patient's response is inadequate, then we need to consider the alternative etiologic possibilities. Simple additional tests like CBC, CRP, and peripheral smear can help to distinguish whether it is a viral syndrome or a bacterial syndrome. Scenario 4. Scenario 4 is almost we need not discuss another patient. We can discuss that the above patient itself, and we know if the patient is presenting with a simple pharyngitis or URI, majority of the time, like 80% of the time, it is going to be a viral syndrome, especially if there is a rhinitis. There is no bacteria which is causing a rhinitis, isn't it? So if a patient is presenting to you with rhinitis, running nose, then we know that it is most likely we are dealing with a viral syndrome. But at least in 20% of the time, there could be super infection with the streptococcus. Once there is inflammation of the upper respiratory and the upper respiratory immune system, the upper respiratory innate immune system is kind of weak, there could be superinfection. But things that the chance of superinfection is very less. It is not like that majority will get a superinfection. Majority will not get a superinfection. Majority of the time, it will heal without the need for an antibiotic. 80% of the time, it will heal spontaneously. But since you know that at least 1 in 4 patients or 1 in 5 patients is going to require an antibiotic, you can practice something called delayed antibiotic prescription. So if you are prescribing an augmentin or amoxicillin, you can prescribe to them, but you can educate them and tell them that like it is likely that you are going to get better in a 2 to 3 days time. But in 2 to 3 days time, if there is some purulence or if there is some worsening of throat pain, worsening of fatigue, or if your symptoms are not completely getting relieved, then you could think of a possible secondary infection, and at that time you can consider starting the antibiotic which I have prescribed. So the something like a delayed antibiotic prescription is also you can practice. So let us discuss the importance of sending appropriate cultures. How is that going to help, or how is that going to change the management or even the course of the patient care? So here we have a 76-year-old female who is a diabetic, presented to OPD with complaints of fever, chills, dysuria, with urine routine examination showing numerous pulses. And we diagnosed, definitely, there is no confusion in diagnosis, it is a simple urinary tract infection. And the doctor has started on nitrofurantoin, which is okay. A simple cystitis requires nitrofurantoin only. But the patient presented to ER again after 3 days with worsening of the symptom. So definitely nitrofurantoin has not worked. Urine routine did, from the ER they did urine routine again, which showed persistence of the pulses. So obviously they had to go for urine cultures, which has been sent. So oral antibiotic has been escalated to parenteral antibiotic, started on injections of triaxone, and sent to ward. In the ward, after 48 hours, there is still no improvement and clinical worsening. So antibiotic again escalated to injection meropenem. So the doctor in the ward thought, what these ER people are doing? They're just started the patient on injections of triaxone, and that is why the patient is not responding and escalated to injection meropenem. But 24 hours later, what happened is that the patient has not responded to meropenem also. The patient crashed in the ward. Patient has been shifted to ICU, intubated, and mechanically ventilated. At that point of time, they called for an imaging. Ultrasound showed obstructive stone plus unilateral hydrourethronephrosis. So this was the original scenario. So now let's examine where did we go wrong to send urine routine and urine culture and start on nitrofurantoin. That should have been the first step or the initial step. Just not urine routine. From the OPD, they should have sent a urine culture as well. Why urine culture? Because this is not our day-to-day female in reproductive phase coming to us with a cystitis. This was a diabetic elderly lady. So the risk factors were high, and the propensity for that kind of lady to go to severe infection is also high. So along with urine routine, considering the comorbidities and the risk factors, we should have sent a urine culture upfront. Then if that would have happened, then the second scenario would have been the patient definitely, since we were giving only nitrofurantoid, the patient would not have responded. She will come back to ER after 3 days with worsening of symptoms, like in the original case. But this time the difference is that we have the ER doctor has a urine culture and sensitivity, and the organism probably will be E. coli, and it's sensitive to injection pip test. So instead of starting ceftriaxone from the ER, they would have started a culture and sensitive appropriate antibiotic. But in what? In 48 hours, there will not be any improvement. But then this time, the doctor who is taking care of the patient in the ward will think in a different direction. So he will think, or she will think, okay, now the patient is on appropriate antibiotic for 48 hours. So if a patient is on appropriate antibiotic for 48 hours, then the patient should respond. If not responding, there is something which we are not addressing. So what exactly it is that we are not addressing? So that would have been the way the doctor in the ward will be thinking. And in order to understand what is that we are not addressing, definitely he will not be escalating to meropenem, but rather because the patient is already on appropriate culture and sensitivity antibiotic. So the imaging would have been ordered just 24 hours earlier, which would have picked up an obstructive renal calculi, which triggered a urologic, which could have triggered a urologic consult and stone removal. And once the stone is removed, then all the pus which has been collected upfront will get drained, and the patient improvement will happen in 48 hours. This scenario, actually, I come across this scenario once I have been posted in ICU. So that is why I thought, like just upfront, if the doctor who like in various scenario, we might be that doctor who might be taking care of this patient in either of this time point. And if we had that kind of thought process to send the culture upfront, or to do the imaging upfront because the patient is not responding, and there is some source which we have not addressed, then definitely that is going to make a big change in that patient's life. Like no ward crush, no ICU transfer, no mechanical ventilation. So again, this is just what I have told. So take home message: always send cultures prior to antibiotics. Even after treating with culture sensitive antibiotic, if there is no improvement, we have to search for potential reason for persistent infection. Imaging and surgical intervention is part of source control we need to do. Not to underestimate age and other risk factors. Scenario 6, again to reiterate the point of source control. The other day, I was speaking with my mentor, Dr. Vidya, who was here in Amrita few years back. Now she had moved to United States. So in our conversation, I was asking how the antibiotic prescription and the antibiotic stewardship activities happening in United States. Then she told a story. She told that she had a community-acquired pneumonia, community-acquired lobar pneumonia. So she was thinking in terms of streptococcus, pneumococcus, H influenza, and she started the patient on ceftriaxone. So the patient has not improved in 48 hours. So she escalated the antibiotic to piperacillin tazobactam. By the time the sputum culture and sensitivity came, and again it showed a streptococcus or pneumococcus. So the initial diagnosis was correct. It was a streptococcus lobar pneumonia only, because it was a community-acquired infection. But anyway, as the patient was not responding, antibiotic escalated to pip test. Once the antibiotic has been escalated to pip test, the antibiotic stewardship team came to meet Dr. Vidya, and they have told that you cannot give pip test in this patient because the patient is already on appropriate culture and sensitivity antibiotic. So you need to change the antibiotic. But then she tried to argue, telling that the patient is okay, that might be the culture and sensitivity saying something like that, but the patient is clinically not responding. Then they also argued back. They told that if the patient is not responding, then you have to look for alternative sources or alternative causes. Definitely, antibiotic escalation based on the current culture and sensitivity, we are not approving. And in US, it is, like once once there is adequate evidence, it's very difficult to argue back and forth. You need to come up with the another reason or solid evidence for escalating the antibiotic. So she de-escalated to ceftriaxone, but still, as the fever persisted, did a CT chest and found that the patient had associated pleural effusion. Aspirated the pleural effusion, it was actually pus. So it was a complicated pneumonia. It was an empyema. So an ICD has been placed, and the patient's fever improved. So this is like again like somewhat like the above case scenario which we have discussed, but again, just to reiterate the point, it is not just about the antibiotics most of the time. It is about more than antibiotics. Sometimes it will be about source control. So if you are giving the appropriate antibiotic and if the patient is not responding, always think about the adequacy of the source control which you have done. So if anyone knows me, they know that I work very closely with neurosurgery team and orthopedics team and other surgical teams. So one time I started seeing a lot of urine positivity from neurosurgery ward. Then I was wondering what did suddenly go wrong? Why so many urinary tract infection happening in the neurosurgery ward? So I started investigating, and I found out that it is not that the patient had symptoms, but a new enthusiastic neurosurgery resident has joined. So whenever he is putting, because most of the time neurosurgery patient, as you know, they will be undergoing some kind of brain surgery, and their sensorium will be waxing and waning. So at least 50% of the time they will have a urinary catheter. So whenever he sends a urine catheter, just to ensure that in case if the patient is developing a urinary infection, or if there is some asymptomatic infection, what the enthusiastic neurosurgery resident did is that he always used to send a culture as well, along with the like whenever he catheterized. And the reason and the consequence is that, as we know, urine is a very good culture medium. So if you or me, anyone who has no symptoms, just taking a urine and sending for cultures, and if there is some delay somewhere, and if the cultures is reaching the lab after 1 hour, it invariably will give us something. So if you are sending urine culture, you have to send appropriately within the 1 hour. Then only you will get the correct bug. Otherwise, you will get some kind of uropathogens. And also, if the patient do not have any symptom, then the bacteriuria, the patient will have some bacteriuria, and the bacteriuria is known as asymptomatic bacteria, because the patient has absolutely no symptoms. Only because you catheterize, you have sent for cultures. So this is known as asymptomatic bacteria, and asymptomatic bacteriuria need not be treated, except maybe in pregnancy, and if you are planning to do some kind of invasive urological procedure. So you want a sterile environment. So that these are the two situations which are exceptions. Otherwise, you won't treat an asymptomatic bacteriuria. So remember that point. Scenario 8, or the last scenario, is a patient following an RTA developed a discharging sinus, came to us, and by the time the patient came to us, the patient already had diagnosed as osteomyelitis. Upon examination and history, he had taken multiple, I understood that he had taken multiple courses of oral antibiotic, which is based on culture and sensitivity, appropriate antibiotic in the past one year, but no resolution. Then I have treated the patient with the same antibiotic, which he has been taking for the past 1 year, and he has cured. He has been cured. He came back to me, and I know that he has been cured. How? What exactly was the difference? Shashank, how did the patient get cured? So this is about duration. Yeah. So because when I looked at the patient's history, the patient received multiple courses of antibiotic, but every course of antibiotic was just 2 weeks duration. Okay. So the patient used to get 2 weeks course of antibiotic, and then that's it. Then after some time, again the patient will have discharging sinus. Then again they will give 2 weeks course of antibiotic. So here you need to understand, not every infection you can treat in the same manner. You will have to consider the duration of the antibiotic according to the infection. So the bone and joint infections, or maybe sometimes things like endocarditis or even ventriculitis, you will have to give a prolonged course of antibiotic. So in this patient, I have treated him for a period of 6 to 8 weeks. Continuously, I have treated the patient. It was an MSSA, so I treated initially 3 nisolate, then later I switched to doxy and Septran, and I continued completed the course of 8 weeks, following which the patient completely has resolved. So you need to understand that it is not just about the antibiotic, it is about, depending upon the scenario, you need to consider the duration of the antibiotic. So these are various few pearls or few clinical scenarios which you need to be aware of, so that you can treat the patients appropriately, and this will make a change in the patient's life. So thank you everyone for joining in. As I told, aim was not to give a class or lecture on antibiotic. It was just a sensitization class, just to make you aware that there are various scenarios, so which we need to be aware of. And once we are aware of these scenarios, then definitely the tailoring of the prescriptions can happen, and the patient will respond. Thank you.
Thank you.
That's it. No, we can stop, right?
Any questions?
Oh, okay.
Residents, if you have any questions, please ask Dr. Dipu. Dipu, I don't think there are any questions. Anyway, thanks for your session.
Okay, thank you.
Good night.
Came late.